Very good afternoon. I'll be speaking on battling retinal disorders, AMD, DME, and RVO by the comprehensive ophthalmologist. So why all together? Well, because all of these are bound by a common thread of injections and maybe laser and sometimes, of course, surgery. Now, all of these can lead to visual loss if not treated early and continuously in some situations. Now, this will be basically a case-based approach, and we'll go in for some algorithms. We'll start off with DME. And in DME, of course, VEGF, plays a major role along with the other inflammatory mediators. And another thing that you need to, really focus on about DME is whether there is center involvement or whether there is center sparing. Now, going back to this, if you have good vision, then of course you can follow up these patients, and unless they get worse, you don't need to, intervene. But however, if the vision is not good, then you can, you have to go in for a FA and OCT, and then depending on whether the center is involved or not, you can go in for focal laser or anti-VEGFs, and then follow up and see whether these are, going the way you want them to. For example, this patient, center is not involved, and you can do laser and get away with it, and vision improves. However, this is a situation where there is a diffuse DME, and you have to, add a couple of anti-VEGFs and then followed by laser if you see the patient is now doing well after 6 months of the laser, hasn't required any further injections. Now, this is a bad DME, multiple number of injections, actually 7 over a period of 9 months, and we initially started with 3 injections of ranibizumab, and after that the patient said that he had no more money, and he wanted us to shift over to anything other than ranibizumab, so we shifted over to biosimilar ranibizumab, and so now after 7 injections, he's 6/18, still needs a couple of injections maybe, and then maybe we can try laser. But it's not that anti-VEGFs always work. So in such a situation, after 3 injections at least, you can switch over to a steroid, maybe dexamethasone or maybe even IVTA, and then this is something that worked, and for us and for the patient, and patient is now 612. That might not be the end of the story, because patient can always have rebound edema. Now, it's very important to holistically see diabetic cases, because after 1 anti-VEGF injection, the patient came back with this, and we looked up the metabolic indices, and these were not good. And so what we did was we asked him to go in for a very strict diabetic control, and for the plaque we continued with the anti-VEGFs and biosimilar again in this case, and also statins. So statins, as we know, have an important role to play, and the patient is doing better. So this was in 2016, and this is just last month. Moving on to CRVO, well, what we treat in CRVO is the secondary complications that lead to decrease of vision. So if the vision is good, you can follow up these patients, and unless there is drop in vision, you don't really need to do much. But if there is subnormal vision, then you have to go in for your OCT, macula, and of course the fundus photo. And depending on whether there is significant macular edema, you need to go in for anti-VEGFs. Steroids also you can use, but steroids are notorious in CRVO patients for raised IOPs. So if there is resolved edema, you are lucky, but many a times it's unresolved, and then you have to repeat injections. Of course, if you have vitreous hemorrhage, neovascularization, or neovascular glaucoma, then you need to consider a combination of anti-VEGF and laser, and sometimes even vitrectomy. And of course, you need to follow these up, diligently. Now, this is after 3 anti-VEGF injections. Patient is doing good, and patient disappears because his problems are solved, and then he comes back after 4 months with this kind of edema. So be prepared for more injections, and you have to counsel the patients accordingly. Now, it's very important not only to look at the clinical picture, but also look at the OCT. Why? Because clinical picture would look fine, but if you have OCT telling you that there's edema, then you need to really retreat these patients. So don't let these patients go. HCRVO, again, similarly treated with anti-VEGF, and after 1 injection, edema has subsided. You can see the hemorrhage is there. There's an ERM here, and you need to really follow up this patient also. BRVO, again, the same story. Good vision, you can follow up. Poor vision, you need to go for an OCT and an angiogram at times if you are suspecting ischemia or neovascularization, and then treat accordingly with anti-VEGFs and sometimes maybe laser. In BRVO, it's kind of the same story. You have to, think of multiple injections at many a times. You can go in straight away for PRN, or a, loading approach also is possible. And once the vision has improved and the edema goes down, you follow up these patients. Now, this is a patient that was referred to us following a laser done elsewhere, and patient had edema. So we went in with an anti-VEGF, And after a couple of anti-VEGFs, patient is doing good. Here's another patient, 8 years back, he had an NVE following a BRVO, and he came back to us recently with this recurrence. And this is to emphasize that even in such situations, if you inject an anti-VEGF, then you stand a chance to gain some vision. Of course, some patients need vitrectomy. And lastly, wet AMD, well, if it's an early case, you just observe with lifestyle changes and modifications. But if it's wet AMD, there's no getting away without anti-VEGF. Of course, geographic atrophy, you follow up, and maybe an LVA is in order. So multiple number of injections, again here, until it is dry. Let's look at some other situations. Not always multiple number of injections might be necessary, but this might be for a short period of time. From 2017 April, this patient has received just one injection. And we have many other examples also of having received just one injection. This is 2016, one injection, doing good so far, no SRF, but you are not always so lucky. So this patient from 2008 onwards, we have been following him up. He has received 44 anti-VEGF injections along with 2 PDTs, and this is the current status. So he's 636 in this eye, but remember this is his only eye, and so it's very crucial. Now, last case, this is a patient that came with in 2014 with a RP, RIP and SRF here, was advised anti-VEGF, didn't undergo because her left eye was good. She's an 82-year-old, and next year she comes back with 360 vision in this eye, 6/9, looks pretty good, barring for this small drusen here. And then after 1 month, she comes with this huge PED and SRF. So this time also I asked her to undergo an anti-VEGF, she refused, and now she comes back with a RP, RIP. So this time she is more receptive, and she's undergone 6 injections of anti-VEGF, and now she is dry, but then you have to follow up these patients. So does it leave any scope for any laser in CNVMs? Well, if it's a distinct extrafoveal CNVM, you can, but the recurrence rates and persistent rates are pretty high. So all of these situations, you really have to follow these up very carefully, and anti-VEGFs are today the mainstay of treatment in these conditions. Thank you for your kind attention.